So my name is Alastair Ager. I'm the director of the Institute for Global Health and Development here in Edinburgh, and also the director of the research unit on health in fragility that is really delighted to be organising a week of events, a global health festival with our colleagues from Sierra Leone and Lebanon. So we're going to give people a few moments to join us for this informal conversation on non-communicable disease. More on that in a second. Meanwhile, Julia is just sharing some slides here of Freetown in Sierra Leone, where Peter Conte will be shortly joining us. We have some slides here from Beirut in Lebanon, where Ibrahim Bouhoum will be speaking with us later. And for those of you who are not familiar with Edinburgh, these are some scenes of Edinburgh before lockdown in terms of the Piper active there, to give you a flavour for our city here that hosts this research unit. Thank you, Julia. I think we can lose those slides now. The aim of the Global Health Festival, there are a number of events this week. If you must have found your way to us through probably some link to the festival, but if you go to www.ruhf-global-health-festival.org, you will find a program for the whole week. And we're really pleased to be having a number of events, some in Lebanon, some coming from our colleagues in Freetown, some film viewings, and then a couple of informal conversations regarding the work that we're doing based here in Scotland, but linking in with our colleagues from those two settings. And in the chat, you'll see that Karen and Jimene have shared that link for us. So please do take a look at that and find other events that may be of relevance to you. We're particularly pleased to have the film viewings, that some of them are quite short, but very apposite in terms of our themes for the week, which are particularly addressing the issue of non-communicable disease, which we're looking at particularly today, but also the issues of mental health. So non-communicable disease and mental health is a twin focus of the research unit, and it's a unit that links the work at Queen Margaret University here in Edinburgh with the College of Medicine and Allied Health Sciences in Freetown, and also with the American University of Beirut in Lebanon. And these three institutions from these three very disparate but very great cities have been working over the last 4 years to look at a range of issues linked to the challenges of delivering health services, but have been particularly looking at these twin threats of a rising burden of mental ill health and a rising burden of non-communicable disease. And obviously this was planned all before COVID hit us, and we're aware, we might touch on it today, of how COVID has contributed and made the situation even more complex in addressing these particular health risks. Now, there'll be an opportunity later in the discussion. We have up to an hour. It's good to have you joining us for some Q&A or for some discussions to share more generally about this and learn a little bit more about your backgrounds and your interests. But we're beginning with this idea of assuming that non-communicable disease, which is the focus of our work, it's a somewhat strange title, and many will know that by this we typically mean things such as heart disease, cancer, stroke, lung disease, diabetes. And in Scotland here, we're increasingly aware that around 2/3 of deaths come from these sort of categories of illness, and we would see up to a year or so ago, we would have seen that previous causes of deaths in Scotland, largely due to communicable disease, infectious diseases, that those had decreased over time, and an increasing proportion of deaths was now attributable to these other causes, which have been given this label of non-communicable, because there's not an infectious agent usually quite so involved in its transmission. Now, clearly with COVID, we've had a really major risk of an infectious disease, but it remains a key concern within the globe about this rising tide of non-communicable disease, that there being a bigger picture, not just in the health system in Scotland, but as we'll learn later in the call through Peter and Ibrahim, also in Lebanon and in Sierra Leone. So we're looking at this category of disease, a little bit about how our health systems are responding to it, a little bit how our public consciousness are responding to this different shape, this different set of illnesses that are now troubling us and causing such a burden on our populations. So I'm delighted to have with us two guests. Peter Conte, who we were just connecting to. I just want to check that Peter's link is working. So can we just say hello to Peter if he's there, just for a brief hello? I can't see him on my screen at the moment, so we may have lost our connection with Peter again. If not, we'll come back to him. And then our other guest, who I mentioned, is Ibrahim Bouom, who is a physician from Beirut. And Ibrahim, do you want to just say a few words of welcome of who you are? And then we'll come back to you a little bit later in our discussion.
Sure, thank you so much, Alastair. So my name is Ibrahim Bouom. I'm a physician by training. I have a background in public health, focusing on epidemiology and biostatistics from both St. Joseph University for the medical background and from AUB, the American University of Beirut. And I had the opportunity to work with the Lebanese Ministry of Public Health in 2017 before joining the IGHT Dean and doing my doctoral studies focusing on NCDs. Back then, I was the national focal point for NCDs in Lebanon. And now I'm doing my doctoral studies, and I have another affiliation with the St. Joseph University as a lecturer in public health. So that's me. Very quickly, back to you, Alastair. And looking forward.
It's great to have you with us, Ibrahim, and yes, appreciating your research studies with us, but also your background in the Ministry of Health and understanding policy and practice in Lebanon. So we'll be coming to Ibrahim a little later. Can I just try again with Peter? I can see him on the screen there. He's currently muted. But Peter, can you hear us? And can I just welcome you to our discussion? And just want to say again, just a few words about yourself in introduction.
Thanks very much. I'm Peter Conte. I'm working with the College of Medicine and Allied Health Science, Commerce. And for the RUHF project, I'm the one at the local level in charge to facilitate the research within both the control and the intervention area. And I've been working with Commerce on different researches before, but I'm based in Bombali, and I've also been working with Voluntary Service Overseas, VSO, before coming to Commerce. And I'm sure I've done a lot of research for them, and that is why we met with Kiran during my work with VSO, and he asked me to support this research because I know the communities and I've been doing a lot of research within these communities. So he asked me to give my support, and I think that is how I came into the research. But basically,
it's great to hear, and I'll come back to you a little bit more later in terms of some of the details of that. But it was just to say hello for now, Peter. So really appreciate that. I should note in context, we want to make this very much a conversation. The work that we're doing is supported by the National Institutes for Health Research, NIHR, which is funded from the UK through funding from overseas development assistance. This is funding from the UK taxpayer to support work that is of real value to people in poverty or people living in low-income settings. So we're delighted to celebrate the work that's being done in both Lebanon and in Sierra Leone. And also, Peter, you mentioned VSO, a long-standing action of the British people in terms of providing volunteer support in key sectors like education and health. And it's a nice opportunity just to shout out the important work that VSO has been doing in many contexts, including in Sierra Leone. So that was just as an introduction, so you know a little bit about the Institute and the research unit, a little bit about Ibrahim and Peter. I'll be coming to Peter shortly, but what we wanted to do, that we're trying to do throughout the festival, things that are fairly mixed media. So I wanted just to present to you initially a short video from our work in El Salvador, and essentially, although the bulk of our work has been focused in Sierra Leone and Lebanon, we've been looking at fragile context where the health system has not historically had to deal with significant burdens of non-communicable disease, either preventing of or treatment of things like heart disease, stroke, and diabetes, the things that I mentioned earlier, but is increasingly, for a number of reasons, and we want to come to look and ask about those reasons, why is this an increasing burden, that these health systems are having to do so. And so the health service in El Salvador invited us to join them a couple of years ago to look at the preparedness, how set up the health system was in El Salvador to be able to deal with the increasing burden that they're experiencing. So Julia's going to share a short video. It's about 3 minutes long with you now, and then I'll come to Peter after this. Thanks, Julia.
En el caso de las muertes por enfermedades no transmisibles, a la cabeza tenemos las enfermedades cardiovasculares, donde pasamos de una tasa de 132 a 145. Otra de las enfermedades que nos está afectando considerablemente es la diabetes mellitus. Y en tercer lugar tenemos la mortalidad por enfermedad renal crónica.
Ya tengo 12 años de padecer diabetes y he tenido bastantes complicaciones. A mí el año pasado me abrieron planta de hipertrofia, pues me ensarté una espina. Ahora resulta que en un hierro trabajando y de ahí perdí mi dedo, pero igual nunca me detiene. Yo sé que tengo que trabajar, tengo mis hijos.
Mi ocupación era la agricultura en el campo. Cuando la enfermedad se me desarrolló ya no pude llevar ni un empleo. Mi forma de vivir hoy, últimamente, la familia me apoya.
It's important to examine the social connection of people with chronic conditions, particularly in trial contexts, in order to understand how they solve their health problems, who helps them, and how governments can improve access to health services for this vulnerable population.
El irte a la persona de manera directa te devela la realidad, cómo la gente le toca enfrentar el problema de salud sin que la institucionalidad del Estado sea el factor protector que debería de ser.
We are using innovative research methodologies proposed by Queen Margaret University in 5 communities in El Salvador. These sessions are participative and seek to evaluate the engagement of communities to prevent and treat chronic diseases in El Salvador.
Que ahí donde vivimos nosotros no tenemos una unidad de salud competente para lo que uno tiene.
El usuario del sistema público de salud tiene esa dificultad. Primero, que vive en zonas de violencia. Yo propongo mejorar la seguridad, ver de qué manera los ecos llegan a los lugares más distantes de las ciudades para que pueda solucionar sus necesidades de salud.
Esta innovación investigativa de parte de la Universidad Queen Margaret sería también un paso inicial para poder incidir en otros elementos que también generan enfermedades crónicas no transmisibles, ¿verdad? Por ejemplo, para prevenir la obesidad, que es también causa temprana de diabetes y de hipertensión.
Thanks ever so much, Julia. Thank you, Julia. And that video just gives us a bit of a flavour of some of the work we've been doing, also some of the themes that we think are so relevant in terms of non-communicable disease. And I don't want to anticipate too much what we'll be saying with Peter and Ibrahim, but clearly I mentioned the engagement with the health system, and there was discussions with doctors and with ministers, vice ministers of health there, but that engagement of the community and of communities in prevention and early detection support for non-communicable disease is clearly a big part of that picture. So we'll be looking at that a little bit later. Peter, I want to come to you now. We're going to be sharing shortly with colleagues a video of work that's been going on reflecting the work you've been doing over the last year or two. I wanted to share, in terms of asking the first question, I wanted to share an experience that I had when I came to Freetown and then up to Bombali, the district where you're working, around 3 years ago. And I'd visited Sierra Leone on a number of occasions previously, just after the civil war, for example, and was struck by the lack of general health provision, the real importance at that time of child health and maternal health, and indeed the control of infectious disease and some other neglected tropical diseases. And I have to say, when I came, I wasn't sure of really how big a question non-communicable disease would be for a busy district health team like there is in Bombali. And I remember going a visit there and being a bit worried that I was somehow imposing an agenda on this district health team. And I was now raising another concern that they should have around non-communicable disease, this new category of disease or separate category of disease, half anticipating them saying, well, we've got lots of other problems as well before we get onto that. But that didn't seem to actually be the reality at all. It really had begun to hit in a very distinct way that this was now a major cause of concern within the district. So I just wondered, from that experience of mine, Peter, just a comment from you, having worked in the health system and just seen things develop, you know, how long have NCDs been a major concern, and what seems to have been driving that greater concern in the country? How have things changed?
Thanks, Alastair, and the entire team. I'm sure the issue of NCDs in Sierra Leone is still a major concern, especially when the awareness has started, because long before now, many people were not being able to diagnose, and some of them just believe it was witchcraft, it was wizard, because or they take it culturally as those are diseases that they were normal before, because they were not being diagnosed, the facilities were not there, and they don't have the opportunity to visit the hospital so that they can be diagnosed. So it remains a challenge until when people have started talking about it, and they've started showing some kind of concern, and now a lot of stakeholders are coming in to see how they can respond, because now non-communicable disease, even for the government angle, there is a special unit, the non-communicable disease unit they've created already, to see that governments will begin to actualize certain measures that they will control it, or they will see how they can redress some issues. And coming to Bombali itself now, with this new intervention, we are sure that a light has started coming to the issues of non-communicable disease, because a lot of awareness have started. And what we did, the first intervention was to train the community health officials. For us here, we call them the CHOs. They are in charge of the chiefdoms within Bombali as a whole. So we train them so that they will go back to their catchment and begin to look at issues of non-communicable disease. The first intervention we did was to look at high blood pressure and stroke and other, especially, and also diabetes was included. So we look at 3 non-communicable diseases, and we said, how can we draw an agenda around this and communicate that one with government, that this is exactly what is happening in Bombali. So
Peter, just before you go on to describe, there's something I think important that you said there that I'd like to open up a bit for discussion. So until this sort of trying to increase awareness, if you like, or sensitivity to that, you're saying that there was a rising tide of, for example, high blood pressure or diabetes, and people would be suffering that within communities, but they would not be accessing, there would be no one actively seeking to detect that, or they wouldn't be, if they went to a clinic for some other complaint, they wouldn't be checked for blood pressure, or they wouldn't be checked to see if there were early signs of diabetes. Is that right? So you're saying that this tide has been coming, but there wasn't the mechanism to pick up those early signs?
Yes, one key challenge is, the first one is their willingness to come to the facility when they are sick to be tested. That's one major problem, because they believe that the first point of contact for them is the traditional healers and not the medical facilities. Yep. So with this awareness now, we've discovered, because a lot of time people will get sick and they will say, okay, I will take these herbs, and I'll get better. But when this awareness started, they now see the reason, the need for them to be going to the hospital for checkup. So now they are being checked. And also the health workers themselves, they were not like looking for those people coming and to do tests that, oh, we are going to do non-communicable disease test on them, diabetes, high blood pressure. They were not doing that. So that was a serious gap. The people are not willing by then to come to the facility, and even the few that are coming also, the medical personnel are not diagnosing them.
I know.
To really help them. If they come with malaria, they will just go ahead and prescribe the drug for malaria, and not testing them actually to know what are the other co-infections.
So Peter, again, just on that's just a really important point. I realise for those of us on the call from Scotland, then when you go to the doctors for anything, you nearly always, I think, have your blood pressure taken. Even I'm not going complaining of high blood pressure, but it will be checked as part of a sort of a routine measure of things, and sometimes there will be bloods taken. So the work that you've been doing, you're saying that's partly changed the culture of the routine primary care, sort of routine initial stages of care, that when you go you may go because you have some worry about a particular disease, but often NCDs are called silent killers, aren't they? People are not aware that they have necessarily these symptoms, that this is an opportunity to be catching up early signs of an illness. Is that a reasonable way of putting it, do you think, Peter?
Yes, because we are talking about two different components here. The regional hospital is just the hub where everyone refers cases that they think they cannot address. But now, mainly our intervention is looking at the peripheral health unit. And there were no doctors at the peripheral health unit. Is these community health workers are the ones they see as doctors at the peripheral health unit. So for them, their normal routine, if a patient comes and said, my head is aching, they will say, okay, take paracetamol or this, and you go down, you rest. So they are not doing further diagnosis to know exactly what are the causes, and also what are the co-effects. And especially for people who are more than 40 years. But after the training of those community health workers, there is a change in culture, in pattern of the way they now have their normal routine services, because there are other diseases that come with age. Yep. So they were advised that for everyone that is coming, you do thorough screening, do a high blood pressure and other tests. So with that one, they've now started drawing the pattern that this is something that is happening. And when we started it, they now begin to communicate, because they also have their platform where every month they come together, they give the district health management team, which is at the district level, like the Ministry of Health at the district level, they give them updates, what is happening, and in turn, those updates from the district now filter to the national.
Cocaine, marijuana, drug, I know.
Sorry, Peter, that we lost you for a second there with another caller on the line. Peter, what I want to come to you just to check one thing. So what you're saying, I think we'll show it in the video in just a moment, that there's been a change in the behavior of the health workers within the health system through the training and through, we'll see the desk guides described in the record card of being able to be on the front foot, if you like, anticipating, checking for these things. There was something mentioned in the El Salvador video I just wanted to pick up with you just before we go to the video, which is there's also work with communities. So you've been working with the health workers to be more aware and anticipating doing tests and so on. Can you just tell me in 1 minute what you've been doing with the communities in terms of prevention and awareness in terms of some of these risks?
With the communities, after the training of the health workers, we now come to the community and we draw a plan. We identify the stakeholders that will support us in this drive, the social mobilization drive. So when we identified a plan, we bring the stakeholders together. And what we did was to introduce the project to them and to own, so that they can own the project. So we asked them to identify key activities that they think they can carry out within their communities to help the research, because the more the information the people gather, the more they change their behavior, the more they change their pattern. So we gave them the opportunity to identify activities, and they identified a lot of activities wherein they themselves will champion the research at their local level. So all we do is to give them the opportunity to like review. If something is not going well, we try to review. So that was what we did on the social mobilization. We gave them the opportunity to be the frontliners, because they can communicate their language more. So in their own local language, they will understand themselves. And if they see the paramount chief is standing before his own people and communicating about non-communicable disease, they will take it more serious. If they see the counselor, if they see the pastor, if they see the imam, those sectors. So that was what we did, was to identify the stakeholders who know that they have influence, and to give them the opportunity to share.
That's great, Peter. So we're gonna cut to a video now to see some of that, and I'll bring you back into the conversation after I have spoken with Ibrahim. And just to draw people's attention, the chat is open. We're going to aim to have time for general discussion and chat at the end, from comments from Peter and from Ibrahim in particular. So if there's particular issues you want to raise, or just reflections you want to share, please feel free to use the chat, and Karen and Julia will monitor it. But Julia, if you could take us to our video. This is just describing some of the work that Peter was just talking about.
Andrew S. Cisse, the lead facilitator during the social mobilization. Andrew S. Cisse, the lead facilitator during the social mobilization activities. The impact we don't create to me, now that's.
Yeah, if you start that again, I think we had a sort of a coverage of the screen, but let's try it again. Thanks, Julia.
Andrew S. Cisse, the lead facilitator during the social mobilization activities. The impact we don't create to me, now that's the number of clients there.
Sorry,
Julia, do you want me to try?
Yes, please.
No, don't worry. I mean, that's
Let's
absolutely.
have one more try of the video, and then I'll come to you, Ibrahim. And we can, if for any reason we can't share it now, we'll share the link with people so that you can view it. And it's just describing the, thanks, Patrick. We'll share the link so people can view it directly later. Let's give one more try.
Let's hope you can all see it, but
that's good for me. I just don't have volume now, Karen.
Ah, okay, sorry, that's my settings. If you give me 1 second, I will do that. Sorry, I'm just trying to get the settings to share the.
While Karen's just sorting that, say encourage colleagues on the call, if you want to reflect anything in the chat, we'll pack up that. We'll be a bit tight for time, but we'll have some time for discussion, and Peter and Ibrahim in particular can address any of the reflections that you have. So while we're waiting to connect to the video, please post any reflections, or indeed your own engagement in thinking around non-communicable disease in the settings in which you're working.
Yeah, sorry, that's not working for me either. I would have to reconnect.
Okay, don't worry. So we've shared the link. Thank you, Mari. So in the link, you'll see, sorry, in the chat, you'll see there's a link there to the video that we were aiming to show. Just to say, for context, that this was a description of both of the two aspects of work that Peter was talking about. One was a training and support for primary healthcare professionals, supporting them in the early detection of non-communicable disease, identification of it, and training and recording of that, and just trying to establish the routine monitoring of symptoms in the way that we would want to in a high quality primary healthcare provision. And that's now being scaled up across Sierra Leone. And actually we'll also share a link in the chat later on, summarizing some of this work, also been influencing provision in Nigeria, which we're very excited about. But then the second aspect of the work, which was just being mentioned by Peter, and you'll see in the video, is around social mobilization. That is this engaging communities in these issues, whether it's on the reduction of salt within diet or exercise or other things. So we're sorry that we can't share that with you just now, but it's in the link there in the chat. You'll be able to view that in your own time. So thank you for your comment, Katie, and we'll come back to that later in discussion. But yes, please, others, encourage you to post. I want to come to Ibrahim. Now, Ibrahim, Lebanon, Freetown, we showed some pictures earlier on. It's a very different context from Sierra Leone. So I want to just start with the first question, really similar that I asked Peter, which is, what are the pressing concerns regarding non-communicable disease in Lebanon? How has that changed over time? Has that become a big part of the agenda, and how long has that been a pressing issue? And you mentioned right at the outset that you were working within the ministry initially in that area. So tell us a little bit about the history of NCDs in Lebanon.
So thanks, Alastair. So yeah, I mean, it's somehow similar, but at an advanced stage. So I mean, many low and middle-income countries are going through the same process, moving from communicable diseases or tackling the burden of communicable diseases to actually having the burden from non-communicable diseases. Lebanon has actually done what we call it as an epidemiological transition, or this shift from communicable to non-communicable diseases early after the civil war that ended in the 1990s. So, or early in the 1990s, we started showing actually from the first epidemiological data that actually we started dealing with non-communicable diseases, meaning cardiovascular diseases, cancer, and chronic respiratory disease, as you mentioned, Alastair. And we've been seeing that increasing trend in the burden of NCDs because of what we expect and we see all over the globe, especially in low and middle income countries, with the improvement of care around maternal health, neonatal health, and so on and so forth. And people move into being aging populations, and with the, if I may say, the impact of urbanization, globalization, and all these factors, societies try to, shift from having to deal with communicable diseases to having a burden of non-communicable diseases because of common risk factors: smoking, unhealthy diet, physical inactivity. In Lebanon, it's been the trend since early 1990s, and it's still the same. The main pressing problem now is that unfortunately we're still having this worrying lack of progress in reducing the prevalence of NCD risk factors, especially among the young generation. And the main reason behind that is this gap in the prevention policy landscape to tackle NCDs. So as we all know, so many evidence-based policy interventions, such as fiscal policies, like here in the UK or elsewhere in Europe, you have taxations on cigarettes, you have kind of taxation on sugary drinks, and so on and so forth.
So Ibrahim, I want to come on to that sort of taxation, I think, in a minute, but just to take steps in the story, can I just ask a little bit about the clinic sort of context that Peter was talking about? So Lebanon has hit significant economic, particular challenges recently, but it's clearly a much higher income context than Sierra Leone. So would it be reasonable to presume that many people would be able to seek access at a primary healthcare centre? They would be routinely tested. They would routinely have tests, whether it be for hypertension or whether it be for diabetes. Is that something that could be taken for granted in Lebanon, or are the problems and barriers to actually accessing, before we get to thinking about longer term prevention, which I think is really important, just tell me a bit more about the experience of the clinic, or the experience of being able to have access to a primary healthcare physician or nurse?
Unfortunately, I mean, and this is an interesting point, Alastair, thank you. Unfortunately, the structure of the Lebanese healthcare system is a bit different from here in the UK in terms of what's the main bulk of care provided, or actually where is the provision of services are happening. In Lebanon, unfortunately, there is a much of focus on providing specialist-led services rather than this primary care approach to NCDs and other illnesses. So the system is much more dominated by the private sector, and people actually seek or ask for support from specialists rather than from a GP or from a primary care center because of the trend in having this privatization of the system that was fostered actually during the civil war. But I mean,
so Ibrahim, if I'm a poorer Lebanese, or perhaps I'm a Syrian refugee in Lebanon, what ability do I have to be able to get into those services if they're mostly private and presumably quite costly?
The majority, yeah, I mean, for vulnerable people, they rely mainly on whether the Ministry of Health, if they are Lebanese, to get some support for the hospital care mainly, and a bit for primary healthcare services, because again, in the Lebanese context, we have this primary care network, which is mainly owned by the civil society. And in Lebanon, the civil society has this role in trying to support communities in service provision, especially in terms of healthcare. So those people rely mostly on primary healthcare centers that are operated by NGOs to get at least, let's say, medicines and a kind of follow-up. But the focus is rather on the cure rather than the care itself, or rather than to, let's say, early detect diseases and try to prevent complications, or try to, let's say, treat hypertension to avoid getting a heart attack or a heart disease later after several years.
So you touched on this, Abraham, and I'd like you to go on to it, and it is a little bit relevant to what Peter was saying as well in Sierra Leone about changes in the economy, changes of eating habits, and so on. In Lebanon, that side of prevention, of thinking about the environment, not just thinking about detection and cure at the individual level, what are the forces in Lebanon that have made NCDs more frequent and making that, you know, a particularly challenging problem? That I know you've been addressing some of them in your work.
Yeah, exactly. So I mean, the main reason, I mean, or if we look at this and to try to summarize it, unfortunately, we have a serious gaps in the policy landscape around NCDs. So this is what I was mentioning around taxation policies, trying to reduce the availability, affordability of NCD risk factors, and literally Lebanon lacked a lot of wasn't being able to actually put in place and implement such policy that can help reduce actually the burden of NCDs, meaning by reducing the incidence of NCDs and reducing the load on the healthcare system, especially now with the economic crisis that we can touch upon that later, which actually puts the whole health sector and other sectors on the edge of collapsing in the upcoming month.
So Ibrahim, can I just ask about that? I mentioned at the start of the chat that within Scotland there are very pressing issues here, and the Health and Social Care Alliance has put together, you know, an interesting briefing, and I think within Scotland there's been this transition away from a heavy emphasis on personal lifestyle to thinking about the environment. I've just got the website open in front of them about, you know, the priorities being about reducing the availability of health harming products, regulating the marketing of products, and there's been efforts within Scotland on minimum pricing of alcohol, clearly restrictions within tobacco and alcohol sales are major issues. I know also, Peter might touch on this later, that within Sierra Leone there was discussion around tobacco control, but that's been quite challenging politically. What about Lebanon? How are those things playing out there?
Actually, as I said, there is a serious gap in that, mainly because of the decades of political instability in Lebanon, and plus adding to that the governance feature within the Lebanese policy making cycles and the policy making processes. Because I mean, in Lebanon we don't have a high level of, let's say, control of corruption or transparency or accountability within the whole government, including how you would expect people engaging with in multi-sectoral actions to put in place policies around NCDs. Might be it might be the same scenario. So technically, because of this lack of looking at NCDs being the problem of the society or the problem of policymakers, and there is a legitimacy or a need to move and actually put in place policies to prevent them. As you said, the focus is more on individuals being responsible of those things, which as you said, clearly it's not the case. And we need to shift the attention from labeling or framing NCDs as an individual problem or NCD risk factors as individual problems towards having them as a societal problems or a public policy problem, and try to tackle them from that perspective, especially that we know from the literature, and we have evidence that those things are cost effective and are more cost effective than just working on educating and just doing some media campaigns to let people know that unhealthy diet is harmful, or cigarette smoking is harmful. Sorry.
Ibrahim, so I think that's a really good focus for discussion. Perhaps we'll throw that open very, very shortly in terms of people's reflections on that. I do remember an advertising campaign about eating kumquats in the UK, which was derided about trying to encourage people to eat more fruit, but it was actually availability and access to fresh fruit in neighbourhoods that's the bigger issue, and how we've understood that shift from individual choice to one much more of environment. Julia and Karen, I'm just aware of the time. What I'd quite like to have a shot, if you're confident, of showing that video from Sierra Leone, to use that as a link. I can share the link. We have a brief video from Lebanon, but we can put that in the link later. I think it would be good to show this for the next 2 minutes, then I'll bring Ibrahim and Peter back for some discussion with everyone else on the call. So thanks, Karen. Do you want to give it a shot?
Mina kadatu kamara, kadatu barumi kamara. Mina desu for the suffer for the match. Mina praise your patience. They don't permit over 20.
Let me try.
Okay, it looks like we've got a problem. I don't know what that phantom green screen, whether there's some
it keeps appearing, doesn't it?
Editor. So we've shared the link, I think, to both of those videos in the chat. So apologies that we can't show them live, but it'll actually be easier for you to view them. We've now got we've got various ways we'll try it, but with less than just over 15 minutes left, I actually want to go to discussion. So what I'm going to do, so there's a couple of questions in the chat which I want to put to colleagues on the call, and please add to that, and not the other things that you're picking up on, Karen. So I'll come to a couple of the questions of Katie in just a minute. But Peter, could I come to you first, just after you've heard Ibrahim speaking, and particularly in that sort of transition of things,
cocaine,
yes, that working at the local level in terms of clinical provision, in terms of the capacities and the skills of health workers, that's clearly important. But Ibrahim is seeing that in Lebanon there's a need at the national level to work, at the governmental level to work in terms of regulation, in terms of taxation, those sorts of things to really change the environment. Is that at all a relevant issue in Sierra Leone as well at the moment, Peter, or not?
I think it's a relevant issue in Sierra Leone, but what the approach we use might be different a bit, because sometimes if government is not willing to have a regulation,
marijuana, drug, I know.
Okay, if government is not willing to have a regulation on certain things that are happening, then you do the opposite. Get the people involved, train them so that they can make a choice. So for us in Sierra Leone, we engage both the government and the community people at the same time. So what we did, we need the political buy-in of what we are doing, the commitment of governments to see that they really support the idea. And also we engage the local people also to know the dangers, especially the high salt intake, which we are talking about. So for us, the two approaches always go side by side. We engage both the government and they are making commitment. We now see they've now established a whole secretariat for non-communicable disease, and they've now taken the step. So what we do also, because now we are more connected to the community people, we are not saying we redundant to those who are selling, but we just create the awareness to the community people that eating too much salt can lead to stroke, can lead to high blood pressure. And now what is happening literally, the community people are now changing their eating pattern. So instead of them eating too much salt, they now eat less. So by so doing, the people who are producing it or the people who are selling it, they were drastically redundant because more people are not going in for it. So whilst we are waiting for government to have a policy on that or increase a tax on that, we also engage the community people. The community people now also have a choice. So that's how we drive the two aspects of it.
That's really helpful,
So,
Pete.
And the other thing also we are looking at.
Guys, that's really...
Yes, it's so helpful. And
okay, let's leave it there,
Ibrahim
Peter.
was talking about
I want to bring in a couple of questions from the chats, Peter. Sorry, we've got a slight lag. But I think that's a really good illustration. So that, yes, the government policy is important, but there's much that you can do at the community level. And I think you're interesting of that interesting example of if you reduce salt, there's economic impact on the salt seller. It shows the broader context of the work, the sort of the economic, social, environmental aspects that we're trying to emphasize. So Ibrahim and Peter, I'll have a little shot of it, but Katie, actually I don't know, Katie, if the question linked to the, sorry, I think there's one audio link that keeps on interrupting us, but we're persevering. So Katie was asking around the links between NCD's mental health and stigma in Sierra Leone initially, but we might want to address that as well, Ibrahim. And I just wanted to say something initially, Katie, which is that it's an interesting question for me because we have focused our work of the last 4 years on mental health and non-communicable diseases, seeing both a separation and a linkage between them, a linkage very much in terms of them having been requiring a continuity of care. They're not sort of brief episodes, they're things that go on for a long period of time and require you to be in good contact with the health system over time and potentially accessing community resources over time. So we see great continuity in thinking about them in the same way, and yet also wanting to recognize, the discrete disease processes, discrete preventative measures that were in relation to them. So it was interesting when we first started our work in Sierra Leone, then the governmental grouping was non-communicable diseases, including mental health, and mental health was understood within that broader umbrella. Ibrahim, can I come to you, because you were working within the ministry in Lebanon in terms of non-communicable disease. How was mental health as clearly in its own way can be seen as a non-communicable disease, but also as a potential overlapping factor associated with non-communicable disease? How was that handled both administratively and practically in Lebanon, Ibrahim?
I mean, it's not just for mental health, but also for all NCDs. So the work that has been done in Lebanon is try to shift actually the environment of where we are providing care from being in that busy environment of outpatient clinics and private hospitals towards a more close to community primary healthcare services. Because and this is the work that the Ministry of Public Health tried over the years to work in a, if I may say, in a collaborative governance way with NGOs and the civil society to strengthen centers and being able to shift mental health care and NCD care from being just around or being delivered actually in hospitals at the secondary and tertiary level towards being actually available as services at the primary care level. And I think there is a good point that you mentioned also about the linkages between NCDs and mental health. We know that there is a if I may say, bidirectional actually a link between NCDs and mental health, in a sense that people with NCDs are at a higher risk of developing mental health because of having this chronic physical illness, and also people with mental health because of their inability to have a good lifestyle sometimes, or being at a chronically, if not treated well, chronically ill health or ill mental health, they are at risk of developing these metabolic diseases, diabetes, and so on and so forth. And the way of actually solving this problem, if I may say, whether it is NCD or mental health or both of them, is to shift the system towards what we call a person-centered model, or what you mentioned, like here in the UK, of you actually being, sorry for the word, captured by GGPs, and to actually being screened for other illnesses, whether you ask for them or for being actually screened for them or not. So this is the approach that actually, unfortunately, in many settings, especially in Lebanon, for instance, we don't still have a powerful structure for that. We're much giving people, how can I say it, not just vertical services, but sometimes uncoordinated services, depending on who can pay and who can access a specialist-led services.
Okay, thanks ever so much, Ibrahim. Peter, I wanted to go to you with this. This is Katie's question, but particularly asking, she notes the word stigma, and I just wondered what your experience of, I suppose there's two parts to the question. It's about the overlap between mental health issues and non-communicable disease issues in communities within Sierra Leone. I'm particularly aware of those community health officers having very busy roles and continually having new expectations of different roles and supports they might have with respect to different disease risks. But also this issue of stigma, and I'm suspecting the stigma is more around mental health issues than the non-communicable disease issues, but maybe not. What's the issue of stigma in the health system in Sierra Leone, do you think, Peter?
There are issues of stigma that are coming out, and they are serious, because if not addressed, it's also damage the kind of population that are willing to go out, especially to be tested and so forth. Because now with the awareness that is going, people are coming out for tests willingly, and they are being diagnosed and told that this is what you do. And if now the issue for us, we know there are many cases that the issue of stigma will play, especially when not being addressed at the initial stage. We know we have a lot of issues in some outbreak that has happened before. But now looking at mental health and the issue of non-communicable disease, for us in Sierra Leone, it is not that kind of wide thing that has happened, because like we are now moving to a stage wherein people can now talk about issues that they think, if not being addressed, can lead to another complication in life. So because of that, you find out that people have people to talk with and to support them. And that is why the government is also now creating some other substations that people can go and report their issues so that they can get. And recently, they established a unit, a counseling unit for each peripheral health unit within the health center. There's a counseling unit, because there are some cases that will go to the facility. They are psychological issues, and not that that they need too much drug on them and so forth. There are issues that need medication, but there are some issues that just need like psychosocial therapy to be addressed. So they created a unit within the facilities, and make sure that the people that are working there, even though the facilities are limited, because for the whole district we have like 100 and some more peripheral health units, but we just have 2. But that is a good start, because those guys who have been sent, they are also now training other people. And there are a lot of young people that are coming from the university as community health workers. Maybe there are some facilities, you have like 3 of them. So the one is automatically stepping into that shoe if they are being trained. So now that is what is happening I am currently in Sierra Leone.
Okay, thank you so much, Peter. And that hints just one thing. It's really useful for me to be able to emphasise. You mentioned at the start of the call your work with VSO, which we collaborated with in piloting this care package for non-communicable disease prevention, treatment at the peripheral health level, at the basic clinic level. And it's really been great to see your work sort of develop something that is both feasible to do in a fairly resource constrained environment that the national ministry has now adopted as a global, as a frame for the whole country, and in the process of scaling that up and taking it from clinic to clinic and district to district. So aware, like you say, for the primary health MHPSS, mental health support, there are lots of constraints to that scaling up, but it's really encouraging that there are some models that now can be shared across the country. We just have 5 minutes left, so I just want to really wrap up one or two things. So big thanks to Julia, Karen, and to Mari, who've posted in the chat the various links. So actually there are a number of videos. We just wanted to show one. We obviously had problems with that in terms of its compatibility with Zoom and that additional screen, but those are all posted in the chat now. So you should be able to access them from there, and please feel free to share those. Everything's very much free to view, share to view. If you have any further problems with it, just get back to us through the Global Health Festival website. We'll be able to get stuff to you. There's a couple of other things we've posted in the chat. I posted a briefing, you'll just see after my name or just before my name, which is a document that very much tries to provide a simple brief in terms of what was done in Sierra Leone and what was copied in Nigeria in terms of making an accessible package for training at the primary healthcare level and the report cards and the training. So that's a useful tool. We encourage you very much to share that. And then I was going to have any final calls for questions, but then we might close. There's a short video. We've just touched on the overlap between mental health and NCDs. And with colleagues, there's some work looking at physical exercise for refugees as a way of also promoting well-being, obviously physical well-being, but also mental well-being. I see you put your camera on, Patrick. So I don't know if you wanted to ask a question, which you're very welcome to just before I wrap up.
Yeah, thanks, Alastair. Hi, sorry, it's Patrick here from NIHR, so the Global Health Communications person. Yeah, I guess that you've got such a wealth of really interesting resources here, and I just wondered if I want to update colleagues. I've flagged up that the festival's happening, but everyone's so busy, etc.
Yeah.
If there's one thing, I mean, are all of these going to be linked to from the festival website? And maybe just if I could ask if you could send me an updated link, and then I can put something in our sort of internal newsletter thing. Monday.
Happy to do that. Yes, we'll
with one easy landing state.
Yeah, very happy to do that, Patrick. And thanks for your support and encouragement and for joining the call. So yes, no, we're very pleased to have very much like the sense we've had, and with colleagues, hopefully the videos bring something to life, and the earlier one from El Salvador also. So thanks ever so much, Patrick. We'll sort that out. So what I want to do, Julie, if you wouldn't mind, if you just take us to the animation. I think it's a good way to close. This is a message in Arabic, but it's subtitled. There's a number of animations being shown during the week, including around NCDs, 3 teaspoons of sugar. I strongly recommend a viewing of that from South Africa. Very powerful message in a short animation. And we're really keen to have materials that are very much accessible to general publics. Really thank you for your time. Thank you for your questions, Katie. And do encourage others of you to join other events for the Global Health Festival. So many thanks. And we'll just go to the close through this animation. Julia, thank you. Do we have audio on your system? There is sound.
حالي متحمس أعمل أي شيء بس فكر بالمستقبل بحس بالخوف وبعتل الهم كل اللي بعمله إني قاعد بالبيت بدي أغير هيدا الشعور بس ما بعرف كيف.
في كتير أشياء بتصير نحن ما فينا نسيطر عليها، وهذا شي عادي. اتذكر في أشياء تانية فينا نسيطر عليها.
شو هالأشياء؟
إنه نضل بنشاط وحركة. بس كون نشيطة بحس حالي قوية، عندي طاقة أكتر لأعمل أشياء أكتر كل يوم، بحس إني مبسوطة أكتر. بس كون زعلانة أو مالي خلق على أي شي بحب كون نشيطة. هذا الشي بيخليني أكتر مبسوطة ومرتاحة مع حالي. أنا بحس بصحة أفضل بس أعمل تمارين، عم بعمل جسمي أقوى كرمال أقدر حارب أكتر الأمراض.
بس أنا ما عندي الطاقة لأتحرك، ما بحس حالي فيني أعمل رياضة.
أمرار بداية التمارين الرياضية هو شي صعب، ولكن مجرد إنك تبلش رح تحس حالك أفضل. كل ما كنت نشيط كل ما كان عندك طاقة أكتر. التمارين الرياضية هي لكل شخص فينا، إن كان صبي أو بنت، كبير أو صغير. النشاطات الجسدية بتساعد على تخفيف الضغوطات بجسمك، هذا بيعملك مبسوط أكتر رياحة وصحة أفضل. كل شخص بالعالم في يعمل تمارين، ما بيهم مين بيكون أو وين بيعيش، لازم بس تلاقي التمرين أو النشاط اللي بيخليك مبسوط።
ቤቴ ሆኜ የአካል ብቃት እንቅስቃሴ ማድረግ እወዳለሁ። በየቀኑ ተነስቼ ፑሽ-አፕ፣ ሲት-አፕ እና ቁጭ ብድግ እሰራለሁ። የመጀመሪያ ጊዜ ፑሽ-አፕ እንቅስቃሴ ለመስራት ስሞክር ለ5 ጊዜ ብቻ ነበር። ከ2 ሳምንታት በኋላ 10 ፑሽ-አፕ መስራት ቻልኩ። አሁን በየቀኑ 20 ፑሽ-አፕ መስራት ችያለሁ። ብዙ የአካል ብቃት እንቅስቃሴ በሰራው ቁጥር ጠንካራ የሆንኩ ነው።
بحب أمشي وأتنشط لأني كبيرة بالعمر، عندي تسنجات، ظهري بيوجعني. لما نشط جسمي عقلي وجسمي بيرتاحوا، أحلى من القعدة طول النهار.
أنا بحمل أشياء ثقيلة بسبب شغلي، وهذا الشيء بيعطيني لياقة جسدية وبيخليني أقوى كمان، وهي القوة بتخليني أتسلق أقوى ولوقت أطول كمان.
الشباب والصبايا لازم يمارسوا الرياضة أقل شي 150 دقيقة بالأسبوع، ونحن كأولاد لازم نلعب أقل شي 60 دقيقة كل يوم. في كتير نشاطات فينا نعملها.
هيدا شي كتير حلو، بس بلكي أذت حالي.
بس تجرب تمرين، ما تنسى تبلش بشكل بطيء كرمال تتأكد إنك عم تعمل حركات مظبوطين. رفقاتك فيهم يساعدوك، ما لازم تكون بطريقة بتأذيك. أمرار التمارين بتكون بدها تحدي أو صعب شوي، هذا بيساعد جسمك وبيعمل عقلك أقوى.
كتير حلو، أنا جاهز بلش تمرين جديد.
واو، شوف أنت تسلقت شي صعب هلأ، أنت كتير قوي.
شكرا كتير، بس كون نشيط بس حالي أقل توتر، نام بشكل أفضل بالليل، حاسس حالي بصحة أفضل وقادر أتغلب أكتر على الصعوبات. هلأ صرت متفائل ومتحمس أكتر لأعمل أشياء أكتر.
Okay, thank you all, and thank you for your attendance at this session, and do hope to see you at another one over the course of the week. Thank you for your questions, particularly Katie, appreciate that, and stay connected with us and enjoy other presentations. And thanks for the team, particular thanks to Peter and Ibrahim for your engagement and your broader work in this area, and thanks to Mari and Karen and Julia and Kimani in the background. Thanks then all, bye.